like to introduce Dr. Jodie Donovan, who is a Boise native and received her medical degree from the University of Washington, go Whammy. She also stayed here and did her internal medicine residency here in Boise and also served as the chief resident. She subsequently began practicing adult internal medicine and is the associate medical director of primary care for St. Luke's Health System. She provides care for a wide range of conditions, including acute care, management of chronic disease, and preventive care. During the summer of 2021, St. Luke's started the COVID recovery clinic to serve patients suffering from post-acute sequelae of SARS-CoV-2 or PASC. And Dr. Donovan leads a multidisciplinary team of folks, including neurology, pulmonary medicine, psychiatry, physiatry, occupational medicine, social work, pharmacy, and more. To date, the clinic has served over 550 patients. She also received St. Luke's Caring Heart Award and the Distinguished Educator Mentor Award from the American College of Physicians. Her favorite color is purple, and she also practices yoga, and there will be yoga today and tomorrow in the evening here. And loves bird watching and training for dogs and spoons. Please welcome Dr. Donovan.
All right. Thank you very much. Hopefully you can hear me in the back, and I'll just make sure to project here. I want to thank Ada County Medical Society for inviting me to speak on post-acute sequelae of SARS-CoV-2, which I know is a mouthful, so you can affectionately call it PASC or long COVID or even post-acute COVID. Pretty much everything right now is off-label for PASC, so I will be discussing off-label approaches. There are some consensus guidance right now, but there are currently no FDA medications or therapeutics that are used to treat PASC. So today, I mean, there's a lot of interest right now in PASC. And right now we're in the beginning of the stages of understanding the pathophysiology behind the why and the how of long COVID. I'll be discussing the overview of PASC, including individual effects, also population health and economic effects. I'll review current hypotheses and treatments under investigation, and I'll also discuss management of selected PASC symptoms, including fatigue, cognitive dysfunction, and cardiac symptoms. When I see patients in the COVID recovery clinic, a common question that I hear is this real? I've been told all of this is in my head, and I do assure them that this is real. Some become very emotional when I say this because everyone tells them that your labs are normal, your workup is normal, there's nothing else I can do for you. Many of the patients that I see are struggling. After their initial COVID-19 infection, PASC patients can develop profound fatigue, brain fog, heart palpitations, to name just a few of the symptoms. And if this happens in working aged families or adults with families, this can dramatically change their ability to work, provide caregiving, and engage in their normal activities. This can lead to unemployment, strained relationships, and decreased quality of life. It is imperative that we in medicine continue to learn about long COVID and promote team-based support to our long COVID patients. So we'll start with a definition of PASC. And the way I like to think about this is the timeline. So acute COVID starts here. It's within the first 4 weeks. And then subacute ongoing COVID is up to 12 weeks. I typically don't see any patients in the COVID recovery clinic until at least 12 weeks or 3 months. And at that point in time, that's usually when I start using the diagnosis PASC long COVID with these patients. I also would like to mention that it can affect multiple organ systems at varying levels. So many times this results in a high variability of presenting symptoms, as you can see here. We are seeing more increasing research that demonstrates that the COVID-19 infection and long COVID that increases the risk of several medical conditions. As you can see here in this initial top panel, this is 1 year after their initial infection that was studied in the VA database, where you see the initial infection can increase all of these medical diagnoses and places double the risk of pulmonary embolism, cardiac arrest. In the middle panel here, I think is probably one of the things that's more concerning, and this is what I'm seeing most often in long COVID patients. Patients in this study that had a diagnosis of long COVID had almost an 80 hazard ratio for dysautonomia, and then 60 hazard ratio, so very high risk of developing myalgic encephalomyelitis or chronic fatigue syndrome. And these patients are the ones that can't get out of bed. They have severe fatigue. The bottom panel here is in the same study, looking again at the VA database. They were looking at 6 months after breakthrough infections. And again, even after breakthrough infections, you can see a higher risk with all of the medical diagnoses presented. So moving on to thinking about population health and PASC. This comes from the American Academy of Physical Medicine and Rehab, and this is something you can go to. It's free. You can play around with the numbers, but essentially what this is showing, and this came out in 2021, the estimated PASC numbers in the United States and also in the state of Idaho. And the model assumptions that it assumes 30% of COVID-19 surviving cases in the United States result in PASC, and that's based on current literature. And that the case data is pulled nightly from Johns Hopkins. And I feel that in 2021, this was much more useful to take a look at because we were counting all the PCR cases. But with the advent of home testing, it hasn't been as useful. And then also we have new variants, we have breakthrough as well. So I think that the way that I look at this right now is it's a nice ballpark. It's about the only ballpark that we have where we can take a look at maybe how many cases are out there. So in the United States, you can see here, there are about over 30 million estimated cases. And then in Idaho in the red, I have about 152,000 cases. So I was curious to take a look at, well, how do these compare to other disease states in the state of Idaho? And so these numbers were taken from the Health and Welfare website. You can see the PASC number at the top, 152,000. Diabetes is 120,000. Cancer, 8,500 per year, and over 100,000 survivors. And with these two diagnoses, you can think about the time, the resources, the therapeutic targets we have, all of those things that go into supporting these two disease states. And right now, at least the ballpark figure exceeds both of those. And I throw on here Alzheimer's only because they had posted the amount of money that was paid by Medicaid in 2020 for caregivers, which was 149 million. I'm seeing patients who are needing new caregiver support. And so I'm concerned about the cost here for those patients and caregivers. So we're talking a little bit more about costs. I'm going to transition into some of the economic effects of PASC. This was a study that came out of the Brookings Institute that was a Census Bureau household pulse survey that looked at the number of Americans out of the labor force due to long COVID. Currently, 2 to 4 million are out of work due to long COVID. And this was in 2022, August of 2022. Lost wages alone is around 170 billion is what was estimated, and up to 230 billion potentially. They went on to discuss the speed at this economic burden may grow will depend on 3 different things. Improved treatment options that increase the long COVID recovery from patients who are severely to moderately or mildly ill, or whether vaccines can reduce the odds of getting long COVID, and we'll talk about that more at the end of my discussion today, and whether repeat infections carry additional long COVID risk. And right now there's a lot of research going on addressing those questions. So I'm going to transition into the fun science stuff. That's why a lot of us are here today. There are several studies ongoing just studying long COVID, the largest, which is the RECOVER trial, which is funded by the NIH. And I'll just move through a few of these. There is some interest looking at immune dysregulation, and it's with or without reactivation of underlying pathogens. So one connection that has been shown is Epstein-Barr virus, or the virus that can cause mononucleosis, can become reactivated after COVID-19. You can also have an impact on gut health. So a microbiota dysbiosis is what it's called. And then there can also be autoimmunity and immune priming when you have primed immune cells from molecular mimicry that is related to SARS-CoV-2 or imitation. And then there's also blood clotting endothelia abnormalities and dysfunctional neurological signaling in the brainstem and or the vagus nerve. So I'm going to move through just a few of these hypotheses and some of the research that is currently published. With immune dysregulation and virus persistence, reactivated viruses such as EBV, like I mentioned, Epstein-Barr virus, are connected to long COVID. And what they found is this leads to mitochondrial fragmentation and severely affects things like energy metabolism. Reactivation of these have been associated with fatigue and neurocognitive dysfunction in long COVID patients. Immune dysregulation can include CD4 and 8 cells, T cells, as well as cytokines. And even patients that have mild acute COVID have been shown to have exhausted T cells, reduced CD4 and 8 cells for at least 13 months. If you have a GI presentation of COVID-19, this has been associated with the expansion of cytotoxic T cells. And viral persistence is a driver of long COVID. There are multiple proteins and RNA that are seen in organs and bodily fluids. One study looked at the circulating SARS-CoV-2 spike antigen, and this was found in 60% of a cohort of 37 patients with long COVID for up to 12 months, compared with 0% of 26 infected patients without long COVID. Thinking about the vascular system, I know that we think of acute COVID causing things like thrombosis. We still see this in long COVID. The circulatory system disruption can include things like deep vein thrombosis, pulmonary embolism, and also microclotting. Multi-organ damage is thought to be a result of the microclotting, and even in low-risk individuals persists after 1 year. This was a prospective study of 70% of 201 patients had damage to at least one organ, and 27% had multi-organ damage. When they looked at a separate group of patients, and this was a year later after their acute infection, in 536 patients, 59% of them had a single organ damage and 27% of them had multi-organ damage. We now know that if you have COVID-19, it gives you an increased risk of type 2 diabetes. And in a VA data analysis, in 181,000 patients with COVID-19 increased the risk of diabetes. The concern here is that organ damage appears durable and that the long-term effects are unknown. So I'm gonna mention myalgic encephalomyelitis and chronic fatigue syndrome. I call it ME/CFS. And this is in part, and these are really the patients that are severely fatigued. And about half of individuals with long COVID are estimated to meet the criteria for ME/CFS. It is a known phenomenon that we do see after infections. It's just not seen to the degree that we're seeing it currently in long COVID. Pathogens that typically are associated with it include EBV, so Epstein-Barr virus, also West Nile, and then reactivated EBV along with HHV 6 and 7 and CMV or cytomegalovirus can also cause these symptoms. 75 of these patients cannot work full time, and 25% of them are bedbound. Abnormal findings in ME/CFS include exhaustion, essentially. You can see that the immune system is exhausted, mitochondria are exhausted, there isn't enough oxygen there, there's also a lot of neuroinflammation. And many of these findings are observed in long COVID. Right now, the PASC research is trying to make a connection between long COVID and ME/CFS. It's really important to understand the pathophysiology first before we can make that connection. And so normally what I tell folks is that if you have a patient that is severely fatigued with long COVID, you want to be careful with diagnosing them with ME/CFS because right now we don't know if that's a connection to long COVID. It does look like that there is a connection, but we're still waiting for additional data. Postural orthostatic tachycardia syndrome, and this is another one that I'm bringing up, otherwise known as POTS. It commonly coexists with ME/CFS, and this is also what I'm seeing in long COVID patients that's more frequently seen after COVID-19. It's associated with a small fiber neuropathy commonly found in long COVID. And symptoms typically include lightheadedness, dizziness, tachycardia. It's relieved by laying down. And a hallmark feature is that the blood pressure stays the same. There's no orthostatic hypotension. The definition is that sustained increased heart rate of at least 30 beats a minute within 10 minutes of standing without, again, the orthostatic hypotension. One study found POTS in 67% of the cohort with long COVID. So moving on to cognitive impairments. We know that cognitive impairments in long COVID are debilitating. One study demonstrated that 22% of patients with COVID-19 at 12 weeks after the infection had the same magnitude as 10 years of cognitive aging. It's the activation of the kynurenine pathway has been identified in long COVID and is associated with cognitive impairment. And the reason why I highlighted that is because we'll be talking about that with a therapeutic target later. Similar mechanisms to Alzheimer's disease and chemo brain have been shown in long COVID. So Alzheimer's disease, there have been a signaling like with amyloid changes in the brain. And then chemo brain has more to do with the myelin loss with the microglial reactivity, similar to what's seen in chemotherapy. So moving into some of the cutting edge current treatments under investigation, what can we do about this? This is a tough one. There currently isn't any FDA labeled medications to treat long COVID. So you probably hear about some of your patients going out and doing hyperbaric treatments, lots of infusions, those types of things, just because they want to do anything to feel better. The viral reservoir is part of the hypothesis with the immune system, where there's anecdotal evidence out there from case reports of long COVID patients seeing symptoms clear up after a course of antivirals. There was one 47-year-old woman who had been experiencing debilitating symptoms for 6 months. And after initial SARS-CoV-2 infection, she was exposed and potentially infected. She tested negative, but the doctors considered her to be at risk for severe disease and prescribed a 5-day course of nirmatrelvir, ritonavir, otherwise known as Paxlovid. And the patient said all of her symptoms cleared up rapidly and completely, and she was able to return to work and even vigorous exercise for the first time in months. There are studies right now investigating the treatment of acute COVID-19 with the same antiviral, which showed a 25% reduction in the incidence of long COVID. So I think, and right now Stanford has a trial that's enrolling patients for Paxlovid treatment. And sometimes I'm offering that to patients if they want to go down to Stanford to see if they wanted to be part of the clinical trial. I usually, if I have a long COVID patient and they're potentially exposed to acute COVID-19, then I'll just go ahead and prescribe the Paxlovid just to see whether or not it might be helpful for them. But right now it's not a treatment option. There is a Stimulate ICP multi-center trial that is in talks to add remdesivir. Of course, remdesivir is an antiviral that has less drug-drug interactions. So talking a little bit about microclotting, the thought is that fatigue and pain can really stem from muscles being deprived of oxygen by microclots to the smallest blood vessels. In this Stimulate ICP trial is rivaroxaban, which is a blood thinner. And interestingly, they're also testing these other medications, including colchicine, which is a gout medication, and famotidine and loratadine, which is antihistamines. Moving on to additional views on microclotting, Bruce Patterson, who has also treated a handful of patients that I've seen in the COVID recovery clinic. He's a retired virologist from Stanford, and he now works for a pharmaceutical company. He's reviewing pravastatin and maraviroc being a anti-HIV medication and then pravastatin being a cholesterol medication. he thinks that fragments of the virus remain attached to immune cells, and this helps to trigger the immune signaling that keeps the endothelial cells activated and the blood vessels inflamed. And what he's found so far in 18 patients, it showed a statistically significant result in levels of inflammatory immune markers and subjective symptoms in weeks 6 through 12. The thought with pravastatin is that it suppresses the expression of fractalkine, which is a transmembrane protein that attaches immune cells to blood vessel walls, and then maraviroc blocks the monocytes chemokine receptor 5, which plays a role in inflammatory signaling. Arethusia praetorius is taking a look at a combination of all of these together, aspirin, clopidogrel, and rivaroxaban, again, antiplatelets in addition to blood thinners. And what they found is in this study is that all the participants returned to their pre-COVID levels of platelet activity, and they reported that their symptoms of exhaustion and brain fog had resolved. And they felt like the result aligns with the hypothesis that microclots are depriving tissue, including the brain, of oxygen. And the last one here is nervous system stimulation, which I find interesting. There's a clinical trial in Spain of direct vagus nerve stimulation via the skin on the neck. And what they posit is that it supports the anti-inflammatory reflex, much like a pacemaker works to bring regulation to heartbeats. So some pretty interesting research, including some novel agents, and more to come here. I'm going to transition now into discussing a case, an illustrative case, and this is an actual case of a patient seen in the COVID recovery clinic. Oh, hi, so you can see. So the case is Mrs. Jones. This is a 43-year-old woman who tested positive in September of 2021. She wasn't hospitalized. She was evaluated 2 months after her initial COVID-19 diagnosis. She was vaccinated prior to her initial infection. The last vaccine was in February of 2021. Past medical history includes dyslipidemia and obstructive sleep apnea. She presents with mental and physical fatigue, brain fog with short-term memory loss, and heart palpitations. And she's an elementary school teacher. And I really did pick her case because I'm seeing a lot of school teachers, because unfortunately they were disproportionately affected, much like healthcare workers in the pandemic. And so I just wanted to point that out specifically for this subset of patients. So starting with PASC and fatigue, 15 to 85%, wide margin, I know, patients experience fatigue. This is where we're at with our research right now. I'm just letting you know. Fatigue is a predominant symptom in 41% of patients more than 12 months later. And common descriptions patients will mention are severe exhaustion after minimal physical or mental exertion. They will also mention that they have a sense of being weighed down all day. After a good day of increased activity, then they have this feeling of crashing, requiring several days of recovery. And most of the time when patients tell me, I always screen for a push crash cycle. So what might happen is they say, you know, I'm trying to keep within my limits, my boundaries of what I can do on a daily basis, but then I go out to the park with my family. I go to on a Costco run, and then the next day I can barely get out of bed. And I just saw a patient this week where she was really excited about engaging in cardiac rehab, and she engaged in cardiac rehab, and that really set off a flare for her, and she wasn't able to work for a week. So, I mean, this is the reality for these patients. Also, persistent tiredness or exhaustion after sleep or upon waking, and it doesn't matter. I mean, some of these patients are sleeping 12 to 18 hours. This is the consensus statement from the American Academy of Physical Medicine and Rehab on the assessment and treatment of fatigue in PASC patients. And I really encourage any of you who are interested in learning more about long COVID to go to their site. I do have a link at the end where you can go and look. They're very comprehensive. It will go through the entire workup and the entire approach to these patients. So I definitely encourage you to do that with multiple different symptoms. They mention here that it's not unusual for patients to have persistent and fluctuating fatigue. And like I mentioned before, the presentation is similar to myalgic encephalomyelitis or chronic fatigue syndrome, which is the MECFS. This is the National Academy of Sciences proposed criteria. It includes a substantial reduction or impairment in activities more than 6 months with fatigue It's new onset. It's not the result of exertion. It's not alleviated by rest. There's post-exertional malaise, which means that they might actually do something, they might actually engage in activities that they normally would do, or maybe push it a little bit harder. And then the next day they're not able, they are very, very tired. Some of them will actually develop flu-like symptoms, sore throat, body aches, that type of thing after activity. Also unrefreshing sleep, and they also need to have one of these two, which is cognitive impairment or orthostatic intolerance. Management for these patients. This is currently what we do in the COVID recovery clinic. Of course, you want to do a good workup on them first. Think about thyroid and cortisol, blood counts, B12, a metabolic panel, ferritin, screen them for sleep apnea, also screen them for depression. The plan here is to treat any of the above medical issues. And if they have comorbid depression, anxiety, adjustment disorder, then you consider the psychiatric evaluation referral for therapy. And you can also consider in these patients fluoxetine, which has a nice side effect of activation that's worked well in some of the patients. And or tricyclic, you can think about nortriptyline there. These patients, typically I refer them to cardiopulmonary rehab with the goal of learning appropriate exercise and energy conservation. With the patients who have severe fatigue, or they are actually fitting that criteria for ME/CFS, exercise is actually contraindicated for those patients because it makes things worse for them. You follow them up in 8 weeks. If they haven't improved, then you can consider adding a stimulant. Armodafinil or amphetamine, dextroamphetamine, if you can find it right now, the IR formulation twice daily, and then convert it to an XR formulation once daily. And we also have low-dose naltrexone on the horizon. We actually started using this in a handful of patients who typically, if they have fatigue that are accompanied by pain complaints. And of course, low-dose naltrexone is used in pain studies along with other things like alcohol abuse. So after evaluation, the recommendation is a titrated activity approach for these patients. And they're really encouraged to perform exercise at submaximal levels. I mean, this contraindicates a little bit of what we know about physical therapy, that you want to continue to increase the levels. You have to do this very, very carefully. And so that's why sending them to rehab is really the best approach. Avoid post-exertional malaise, which again is a diagnostic criterion for ME/CFS. And there was a study of long COVID patients that demonstrated physical activity worsened the condition in 75% of these particular patients, and less than 1% saw improvement. Like I mentioned before, exercise is harmful for those patients who truly have ME/CFS. And I always talk to these patients about the 4 Ps. So pacing, prioritizing, positioning, and planning. Pacing themselves during the day, thinking about what their energy is like when they get up in the morning, because they'll have good and bad days. Prioritize what they need to do during the day and during the week. Position themselves, and this even applies to folks who are 25 years old. Maybe they need to get a shower chair. Maybe they need to lay down when they're talking on the phone, because sitting up sometimes is actually taking up too much energy for them. And then also planning that goes along with pacing throughout the week. In addition, some of the lifestyle measures like meals, you can do small, frequent meals high in fiber, and complex carbs can lessen the symptoms. So moving on to PASC and cognitive changes. This is similar, like I had mentioned before, to metabolic encephalopathy versus post-concussion syndrome versus chemo brain. Interestingly, attention and concentration is most affected when you look at the domains for memory. And I work with Dr. Audi Black, who's a neuropsychologist in the St. Luke's Health System, and we speak on a monthly basis about these patients, since he sees them preferentially in our system. And it's very interesting, some of the research that's coming out. And so what ends up happening is these patients look like they have ADD, so attention deficit disorder. And a lot of times for these patients, it's very disconcerting, especially with a lot of the other symptoms that are going on for them. So for these patients, these are the things that I would order for them, as far as, again, a thyroid, B12, metabolic panel, inflammatory markers, and a vitamin D. You want to screen them with your favorite screening tool, whether it's a MOCA slums, MMSE, a depression screening, and then also screen them for sleep apnea. The plan, again, is to treat any conditions above. If they have depression, then you can start the fluoxetine. You can consider bupropion. here. And if they have chronic fatigue, you can also start an SNRI in this situation, like a duloxetine or venlafaxine or a tricyclic like nortriptyline. And in these patients, you can also consider stimulant therapy. Again, I mentioned amphetamine, dextroamphetamine. You can also consider some of the other longer acting ones as well. I would say I've had a handful of patients respond very well to this. There's others that it makes them very anxious. So you have to think about the other presenting symptoms. Melatonin for these patients works very well 2 hours prior to bedtime, and you want to avoid those Z medications, so zolpidem, for example, in these patients. I refer many of these patients to neurospeech therapy for evaluation and therapies just for brain, for pacing and how to organize and utilizing things like our smartphone. You also want to think about CBTI for concurrent insomnia, and neurooccupational therapy can be very useful for those patients who are in that category where they need to go back to work. They also focus on things like cognitive pacing and then physical and energy management. I always get the question, when do you do a formal neuropsychology evaluation? This is really reserved for patients that have a high-risk occupation, or if they need to distinguish a high emotional state, such as anxiety or depression. And sometimes, I mean, initially we were sending more patients over to neuropsychology, but now we learn more about the cognitive changes that not as many patients need to go to neuropsychology to do the entire hours-long battery of testing. And there's a rare need for MRI unless there's other neurological symptoms. So I'll mention here, this is just one of the novel treatments that we're starting to use in the COVID recovery clinic. This is based on a Yale study in 2023 with guanfacine, and 1 milligram at bedtime for 1 month. And if it's tolerated, then we increase it to 2 milligrams. And then also N-acetylcysteine, which you can just get over the counter at 600 milligrams daily. And again, like I mentioned, our study included 12 patients because that's where we're at right now in the long COVID literature. More to come, right? And basically 2 patients stopped guanfacine due to dizziness or hypotension, which are known side effects of guanfacine. And then 2 patients were lost to follow-up. And what they found is that the remaining 8 patients reported improved working memory, concentration, and resumption of normal workloads. And the researchers felt like the improvement in the patient symptoms was so significant that they were posting this all over. I mean, I saw this on Instagram, all of these places. And actually, when we took a look at it, and normally whenever we try any of these treatments, I am talking to our clinical pharmacist, who I have an infectious disease clinical pharmacist as part of the team, in addition to the rest of the multidisciplinary team, just to get their input on, whether to move forward with these. And we have right now, we're trialing it in about 5 patients right now, and some of them have had some benefit, but it's only been about a month, so more to come here. And this, I'll just let those of you who really like to look through the biochemistry take a look at that. But essentially what you're seeing here is that COVID-19 increases this kynurenine. So that's what I mentioned previously. And what ends up happening is that COVID-19 weakens all of these signaling. It actually removes the synapses by microglia. And what happens with the NAC and the guanfacine strengthen the connectivity of all of these, of the neurotransmission. Moving on to cardiac symptoms, because I've talked a little bit about POTS. So patients will present with palpitations and chest pain. These are the types of things to think about, of course, with an echocardiogram, EKG, and if they have palpitations, you can think about a Holter monitor or a cardiac monitor. The plan is that the workup's normal, then you treat musculoskeletal pain. And I have to say, most of the time the workup is normal, or maybe you might find some premature ventricular contractions, or, I mean, I'm surprised every so often I'll find some ventricular tachycardia or something along those lines, but normally it's pretty normal. And especially in women that I've seen, they tend to present and say that they have this chest pain that's right here, and right here in the center of their chest, and it maybe wraps around, and it's just really uncomfortable when they breathe. And of course, doing an appropriate pulmonary workup, which we're not focusing on today, But with those types of patients, I'm convinced that it has more to do with either a musculoskeletal issue versus a nerve issue. And many of these patients have responded very well to things like meloxicam, which is an anti-inflammatory, or pregabalin. And I like pregabalin a little bit better in some circumstances than gabapentin because it has less side effects. And most of my patients who never take any medications are a little bit more willing to stay on pregabalin. You can also consider an empiric proton pump inhibitor and or think about aspirin. I probably use aspirin less at this point. And then of course you do the appropriate workup. If the monitor is abnormal, they go to cardiology. If the monitor is normal, then you can consider a trial of diltiazem or metoprolol. Of course, if they have any heart failure with a reduced rejection fraction, then you can treat that or refer them to the heart failure clinic. And if you or your patient ever wants a cardiac MRI, then refer to cardiology. So moving to POTS, so postural orthostatic tachycardia syndrome. Again, I mentioned the diagnosis before, but this is important. So it includes an increase in the heart rate of 30 beats per minute or increase to 120 beats per minute within 10 minutes of standing. This is actually really hard to capture because some patients, they don't exceed this 120 beats until maybe minute 8 after standing. So you can consider thinking about having to do this within your own clinic. And if you're seeing patients every 10, 15, 20 minutes, you could understand how it might be a little bit challenging in your clinic to try to capture this for your patient. But you do have to wait at least 10 minutes. And there's some of them that won't pop up into that 120 range until after about 15 minutes. But technically, it really should be within that 10 minutes. And again, like I mentioned before, their blood pressure is stable. In these patients, you can consider doing a metabolic panel, blood counts, thyroid, and EKG. And then some of these patients, a tilt table actually might be helpful. And it's because in the dysautonomia literature, they have a very specific way that their heart rate comes up and down with the tilt table. That's different from other types of dysautonomia. Okay. So what do we do and then you can also consider ordering in select patients a cortisol echocardiogram, plasma catecholamines. Of course, we're thinking about a pheochromocytoma, and then a tryptase, which is for mast cell syndrome. The plan here for the patients, they can go to cardiac rehab, although some of them don't actually tolerate that. They have to take a break and then come back. The salt intake, they really need to increase the salt intake to 3 to 5 grams a day. Of course, we're thinking heart failure patients, less than 2 grams a day. This is 3 to 5 grams a day. It's really hard for them to get that much salt in their diet on a regular basis. And compression garments, elevate the head of the bed by 4 to 6 inches, and then small frequent meals. And in cardiac rehab, I always let the folks know that it can take up to 4 to 6 weeks of exercise before they start to feel the benefit. And the goal for these patients is 30 to 45 minutes, 4 times a week. Okay, let's wrap back with our case. Mrs. Jones, what happened to her? So for her fatigue and dyspnea, she was referred to cardiopulmonary rehab. She completed a 4-month course with improvement. For her cognitive difficulties, she was evaluated by a neuropsychology and diagnosed with a mild cognitive impairment. She didn't tolerate stimulant therapy for the cognitive issues and fatigue, so she was recently started on guanfacine and NAC, or N-acetylcysteine. And then she also saw speech therapy and occupational therapy for a back to work plan. For her heart palpitations, there was some premature ventricular contractions on cardiac monitor. She was started on metoprolol, which improved those. And then when she was started on guanfacine and NAC, her metoprolol was discontinued. So that is an important point, that if you do go down this road with patients, that guanfacine, if you have a concurrent beta blocker, you need to stop that before starting guanfacine. This was discontinued without an increase in her heart palpitations. She quit her job teaching, unfortunately, because of the cognition issues and the fatigue, but she hopes to return in the spring along with rehab support. All right, so with the last few minutes that I have, I'm going to be discussing a topic on PASC and vaccines. I always get questions on these so how can possibly vaccines either prevent long COVID? If you have long COVID, can it treat long COVID symptoms? Do you get better? And I would have to say it's all over the board right now. I've looked at almost all of the studies that come through, and there is a wide variety of findings. I would say that the majority of time, and this does differ among studies, in part because of the differing study methods and looking at time since vaccination, which I think is a big one, because in general, if I've seen someone that has significant long COVID and they've been vaccinated, it's usually that their last vaccine was at least more than 6 months ago. And so there's a time element there, in addition to our current definitions of long COVID, because we don't have any defined definition yet of long COVID. Most of the time, I would say that most of the studies are showing some improvement or some protection with the vaccines, but there are other studies, probably a handful of studies that I have reviewed that show no difference. So I've just put a smattering of those studies in through this last section. This first study, there's just one study. This was probably the most recently published one. One study indicated there was really no difference in PASC between, or the rate of PASC between vaccinated and unvaccinated people. So I'm thinking about, well, does this actually, if you vaccinate before the infection, does this help prevent the development of long COVID? There was a prospective case control study that found that 2 doses of vaccine before an infection reduced the risk of prolonged symptoms after 28 days compared with unvaccinated matched controls. And then in addition, other studies have indicated that vaccines provide partial protection, reducing the risk of long COVID between 15 and 41%. And so what happens in patients after the infection, if you vaccinate after they've already been infected, vaccination within the first 12 weeks was associated with a reduced risk of developing long COVID on this basis of a retrospective analysis. And this was in over 240,000 infected persons. And then the last question I get quite often is, well, what happens in long COVID patients? What do vaccines help? Do they hurt? Because many patients, when they come in, especially because as terrible as they're feeling when they come in, they don't want to do anything else that might actually worsen their symptoms. So this is probably the last study that I've seen published, and other studies I see about the same maybe outcomes, but vaccination after diagnosis of long COVID really differs amongst patients. Maybe 16% of them find a relief of symptoms, 21% note a worsening of their symptoms, and the remainder, their symptoms are unchanged. I would say anecdotally, just seeing these patients in clinic, that I'll ask patients, well, how did you feel after you were vaccinated? And I would say it's probably, many of them will say, I didn't really feel any difference. Some of them will say, yeah, I actually felt worse. And then there's maybe a handful that will tell me that I actually felt better. Okay, to sum up today, thanks for coming with me on my journey. So post-acute, PASC, long COVID, these patients, they really need to benefit from a multidisciplinary care approach, considering speech therapy, physical therapy, occupational therapy, cardiopulmonary rehab, and lifestyle medicine, in addition to any subspecialty referral for these patients. And I do think that this has the potential to become the next public health crisis. Like I just mentioned, vaccines appear to have some partial protection against PASC, and effects, though, can vary with patients who already have PASC. Primary care, so I do see some of my primary care colleagues in here, will be the primary evaluators and managers of post-COVID care. I highly recommend keeping updated with the post-acute COVID-19 education locally or nationally. And if you have any referrals, have any questions, have any complicated patients, refer to St. Luke's COVID Recovery Clinic, because we are taking all referrals currently. If you've referred previously, we had to place a little bit of a hold on our referrals, but now we're up and running again. Here's all of my references. And these are the additional resources and contact information. So this is the AAPMR guidance statements. So like I mentioned, if you're interested in looking into these more comprehensively, the CDC, and then my contact information. I'm happy to answer any questions from anyone. So thank you very much.
Is it, do they meet criteria for kind of acceptance?
So that's a great question. Yeah, so your question, so actually let me restate for the folks that are online. Do the patients meet criteria for cardiopulmonary rehab? So you definitely have to use a diagnosis. So if they have something like POTS, then they meet cardiac rehab criteria. If they have any shortness of breath at all, and then they would meet criteria for pulmonary rehab. It is sometimes challenging for some of these patients to get covered, especially if they have no pulmonary symptoms because of the way that insurances are currently covering. Correct.
And then I have one more question about PT. Is it just regular PT with surgical too?
So yes, so there are many, so they actually have several, so in St. Luke's health system, we have several physical therapists that are aware of how to treat long COVID patients, but you do your community want to know the physical therapists because not all of them are aware of how to treat long COVID patients. Because if you send them to a regular physical therapist, then they may actually have, they may unfortunately make them have the post-exertional malaise, and we want to avoid that. Correct. Yes, they'll have a, yes, so in the St. Luke's health system, they will triage that to someone who knows how to approach the patient. So normally, so I would say in so if I see a patient that has pretty significant fatigue, I am screening for EBV in addition, right? And usually I just use the EBV panel that's available to me within my health system, because normally if I type in EBV, there's an EBV panel that pops up with all of the markers. And I would say that, and the reason why I do that, at least right now, is because of all the connection. I can't tell whether or not if it's the reactivation of EBV, Epstein-Barr virus, that is causing some of the symptoms. It's really hard to know in some of these patients, but at least right now, it gives me at least a perspective on if they have reactivation of EBV. And I'll mention that I've probably seen it in that particular subset of patients who have severe fatigue, or they're looking like the ME/CFS picture. I've seen it at least half patients come up with EBV reactivation.
I have a quick question on the patient. Is there any classic characteristics that have been kind of brought out, like males more than females? The second part of the question is, people get critically ill with COVID-19 and survive, do many of those have long COVID? Not in my experience in the clinic, but I'd like to hear from a broader perspective.
So the question for those online is more demographics, question about demographics of patients with long COVID, and then for patients who have been hospitalized with severe COVID, whether or not they have long COVID. So I can answer the first question. Right now, there isn't like a demographic that is more affected than another. I think what I'm seeing is that I'm surprised to see a lot of young patients. I mean, I've seen 18-year-olds. We frequently get requests to see teenagers in the clinic, which normally we'll see down to about age 16. Otherwise, we refer them to OHSU, that has a pediatric long COVID clinic. But I would say right now, it's not female male predominant. There are some symptoms that are being seen more in women versus men, more like the chest pain, especially maybe anxiety. But I would say some of the other demographics, especially for developing anxiety or depression after having long COVID and then having no history, usually those patients have at least some history of maybe some mild depression or anxiety before having COVID-19. But we do know that in those patients, COVID-19 can actually change brain chemistry and cause anxiety and depression. So I would say, and I think to your point, elderly patients, we aren't seeing this as much, but I think it's also because we're not focused on elderly patients as much with the long COVID, only because we're thinking about our working aged adults. So I think that we probably end up missing a lot of these symptoms in our older population because we just kind of brush it off as, oh, they're getting older. It's cognitive decline that's going along with age. So I think that there'll be more to come, I think, with the research coming out, but those are the things that I think about when I see the patients. To the second part of the question of the patients who have pretty significant COVID-19 in the hospital. So let's just say that they were ventilated for a month and then they had to go to a facility and then they were discharged back home. Those patients tend to have a lot of respiratory. I would say that those patients actually have a lot of dyspnea, and maybe they also have associated chest pain. They usually have associated fatigue related to both of those, but interestingly, I don't see as much cognitive changes with those patients versus the patients even who might have mild COVID-19. So it is interesting, but I will say in the clinic, I also do see a subset of patients who have had pretty significant illness who come into me on oxygen and those types of things. They're also usually followed by a pulmonologist.
Is there an association between long COVID and Guillain-Barré?
That's something I've seen in the literature. And as far as I think with COVID-19, or the acute COVID-19 infection, there's been some cases that have come out with Guillain-Barré, but I haven't seen it as much in long COVID patients.
I have a quick question. You mentioned low-dose naltrexone as the therapeutic approach. Could you expand on that into dosage, duration, formulation?
I know right now I have to say that it is experimental. For the most part, what we decided on in our clinic is we decided we would trial something along the lines of like a 10, maybe milligram dose and see if we can increase from there. And basically the idea would be following the other, at least very bare minimum case reports right now, literature that has been published is increasing that every month to see if that does help with some of the fatigue and the pain. And it's just and we decided to use the naltrexone, just the regular formulation for that. And so right now I'm hoping that right now I know that there's studies going on and I would love to have more guidance on that, but we closely follow those patients to ensure that they don't experience a lot of side effects on it either. So we're looking for all of those things while we're following those patients. Usually, well, we just started using low-dose naltrexone. So I would say that we just started this process, but it is probably going to be at least like a 3-month process and then to see whether or not they improve. If not, then we'll go ahead and take them off of it. Thank you for the question. Online, I'm doing this intermittently. Online, the question was Aricept for treating cognitive issues. I don't know of any trials right now that are looking at Aricept specifically. I think it would be an interesting trial for sure, but not right now.
Jodie, in regards to vaccination and non-COVID, what is the current recommendation for duration after they get acute COVID illness to vaccination?
So that I would say that you could vaccinate probably at any point in time right now. From a long COVID perspective, normally I'm waiting at least a month after the acute illness. And I do recommend for the long COVID patients to be vaccinated. I am letting them know though about the current studies so that they are fully aware.
Can you comment on correlating
Yeah, that is something that we have. So there's nothing I would say in the literature right now between the different well, I think that there's starting to come out some of the literature between the different strains. We've discussed this quite often in our multidisciplinary team and the team members who are currently seeing the long COVID patients. I would say that because we're still seeing patients from 2020, and I would say that the alpha strain and the delta strain, they tend to have a lot more pulmonary. I think that that's what we were seeing even from an acute perspective, pulmonary symptoms. As far as cognitive symptoms, I'm actually seeing more probably in the Delta and Omicron waves, and even in patients who have had some of the more recent variants, especially from a cognitive and fatigue standpoint. With that, I mean, then we start thinking about, is there an autoimmune component? And I would go down the autoimmune pathway, and then you can screen with an ANA, or if you need to get more information from the patient, then get more information and then screen with an ANA. And a lot of, at least the panels that I use, end up reflexing if it's positive to a whole host of other markers. So that's probably what I would do from approach. I would say most of the time, though, that the inflammatory markers are normal in many of these patients, unless that they were hospitalized, and they tend to be these patients that always have this elevated CRP, ESR, D-dimer. And I just kind of follow that over time and maybe watch that with their symptoms.
How do you think like on versus that versus stronger stuff?
Yeah. Quite frequently, so part of it comes from, sleep medicine literature, but then we also discuss this with one of our pulmonary specialists on the panel, in addition to our psychiatrist. And so that's part of the reason why we decided on this specific approach. But there's not any current long COVID literature right now, but that was more of like expert opinion. Yeah. Mm-hmm. Some will, yeah.